Good afternoon, and welcome to our series of webinars focused on bringing you information about COVID-19 related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities, but we encourage everyone who's interested to attend. Today, we'll be discussing colonized versus inactive MDROs, or multidrug-resistant organisms. Everyone has entered the meeting on mute, but we will have a discussion following the presentation. If you have questions or comments, please submit them using either the chat or the Q&A tool in your Zoom menu. You can also raise your hand to request to be unmuted to ask your question out loud. We invite you to join us every Wednesday at 2 p.m. for more of our weekly webinars. Next week, we'll be having an open Q&A on all topics with our full panel of health experts. If you have a question you'd like us to discuss, you can submit it in advance using an online form, which I will drop in the chat shortly. That webinar will be the same time and place next Wednesday at 2 p.m. My name is Kathy Caudill. I'm a communications specialist with Quality Insights. And now I'd like to introduce our guest, Dr. Jean Storm. Dr. Storm is medical director here at Quality Insights. She has a background in nursing home care, internal medicine, and healthcare leadership. Most recently, she served as associate medical director for Optum United Healthcare. She has also served as regional medical director for 38 long-term care facilities in West Virginia. She earned her DO from Lake Erie College of Osteopathic Medicine and completed her postgraduate degree training at Mill Creek Community Hospital in Erie, Pennsylvania. Dr. Storm, thank you for joining us again.
Thanks, Kathy. So today we're going to be talking about the difficult topic of multi-drug resistant organisms. And I said in the title that it's a slippery slope. And I have found in my clinical practice that it is definitively difficult to figure out when we need to treat. And we know that treatment is not benign. I was talking to a physician the other day, and I was discussing about antibiotic use, and this is a surgeon, and he said, well, we would just treat that with antibiotics. And I said, well, that's really not what we're supposed to do as physicians. So, it's something that I think physicians don't often think about the impact that we have when we start antibiotics. So we really have to be careful and have a good framework to know when we're going to be initiating antibiotics and for what. So I wanted to start talking about Ignaz Semmelweis, and he was a obstetrician, and he was an early pioneer of antiseptic procedures. So Dr. Semmelweis would deliver babies in a hospital where there were 2 units. And in one of the units, nurses at that time would be delivering the babies. And then there was another unit where physicians would be delivering the babies. What he recognized was that in one of those units, there was a very high rate of sepsis following mothers delivering their babies. So he did a quality improvement project and gathered some data, and he realized that the unit that had the high incidence of fevers following childbirth was the unit where the physicians were delivering the babies. And what he discovered was that the physicians were doing autopsies between delivering babies. So they were bringing the bacteria from the autopsy specimens, and they were not washing their hands in between delivering babies. So he pioneered antiseptic technique, and he proposed the practice of washing hands with a chlorine solution to prevent the spread of infection in postpartum mothers. Needless to say, he was profoundly ridiculed, and he actually ended up going crazy because he tried to push this issue so much that he ended up in a mental institution, and he actually ended up dying there, unfortunately. So what is an MDRO? It's a multi-drug resistant organism. It's typically a bacteria, and these bacteria are resistant to one or more classes of antibiotics. They are frequently resistant to the most common classes of antibiotics. We're talking about penicillins, the very basic antibiotics that we would go to for our infections. MDRO infections, we know, are associated with longer hospital stays, increased costs, a higher incidence of people dying. These are infections that are very difficult to treat because we have fewer antibiotics available. I don't know if you've ever seen a urine culture with a multi-drug-resistant organism, and it is very challenging, especially if the patient has antibiotic allergies, if they have compromised renal function. So you are exceedingly limited in the antibiotics you can choose based on what the organism is resistant to, what the patient is allergic to, and that some drugs that you can't give because of their renal function or other factors. So MDROs are becoming more prevalent, and they've increased dramatically, especially in nursing homes. MDROs have definitively increased, and I would argue that the nursing home setting is caused the increase in MDRO infections. So what are examples? MRSA, we all know. MRSA's been around for a long time. In preparing this, I saw that it was first discovered in 1968, so MRSA's been with us for a long time. VRE, vancomycin-resistant enterococci, ESBL, which is our extended spectrum beta-lactamase producing gram-negative bacteria, and CRE, carbapenem-resistant enterobacteriaceae. There's others coming all the time, emerging as we speak. This is just what bacteria do. They want to be able to be resistant to antibiotics in order to survive. So common sites, respiratory tract, heart valves. We've all seen MRSA, endocarditis, skin and soft tissues. I'm sure you've seen MRSA infections in the skin, osteomyelitis, so infection in the bones, gastrointestinal tract. Urinary tract is a big one. I'm sure we've all seen MDRO infections in the urinary tract and other locations. So we're going to talk about colonization versus infection. And I think that this is a really important point. And I believe in making things very simple. I think simple is the way to go. So when we look at colonization, colonization means that a potential bacterial pathogen is present on or in the individual's body. This might be an MDRO bacteria. It might not be an MDRO bacteria. So individuals, people who work in healthcare, patients who've been in the hospital might be colonized with MRSA. This does not mean that they have an active infection, and this doesn't mean that they necessarily need treatment with antibiotics. It does increase the risk for infection. So if a patient is colonized with a bacteria, an MDRO bacteria, they are going to be at risk for infection with the bacteria. And we're going to talk today about how we recognize infection so we know when to initiate antibiotics. So that's the most important thing to recognize. When an infection is present, so we know when to initiate antibiotics. So individuals who are chronically ill, immunosuppressed, who have been admitted to the ICU, these are a lot of our nursing home patients. These patients are at increased risk to get an infection from a colonized MDRO or other bacteria. So we have to keep this in mind. Endogenous versus exogenous. We don't need to just worry about infection that's present on a patient's body. That's endogenous. So that's when an individual develops an infection from a bacteria that they are colonized with, that's on their own body. Exogenous means the patient develops an infection from a source outside their own. So it could come from a surface, or it could come from another individual who is colonized with a bacteria. This is why it's really important for us to realize that the whole nursing home is a unit. It's not just one patient isolated. Each patient, every patient, we're going to have a whole, they're going to affect each other. So that's why we have to keep that in mind. I found this study very, very interesting about MRSA. So this study was done, it was a survey about nursing staff perceptions of MRSA, and they polled nurses and nursing assistants. And the first question was, antimicrobial resistance is a national problem. And you'd think, yes, most nurses would agree, most nursing assistants would agree. So most nurses agreed that it's a problem, it's a national problem, but that was a little bit lower for nursing assistants. When you ask these same individuals if antimicrobial resistance is a problem at their own facility, those rates dropped, right? So they say, this is really typical just of human behavioral in general. It is a national problem, but it's not a problem here, right? But we know that's not true. We know that MDROs are a problem nationwide in every facility, hospitals, nursing homes, every healthcare environment. So this is just what it demonstrated. And most nurses and nurse assistants didn't feel that they were at risk for getting MRSA, but they did feel that their patients were at risk for getting MRSA. So super interesting study. I think this just needs to draw attention that, ourselves and our staff, that we all need to be aware that it's not just outside, it's not, somewhere else, that it's in our own facilities. So when we talk about MDROs, we're walking a fine line because it's important to recognize infections early, because we want to, in our nursing home residents, we want to recognize these MDR infections early because they're so severe. So we want to prevent lengthy hospital stays. We even want to prevent hospital stays altogether. And we want to prevent death because MDRO infections are serious in our patient population. But we really need to be judicious with our antibiotic prescribing, because the more antibiotics we use, the more resistance that we create in bacteria. So the more bacteria we use, the more MDROs we're creating. So we have to be really careful and thoughtful about when we initiate antibiotics. A study done in 2020 illustrated that almost half of all residents are colonized with an MDRO. So this is really good information to keep in mind when we get culture results and the individual does not have symptoms or signs of infection, because then we know that 50% of our residents are colonized. So this was a study that was done. The top portion, this number one, was the number of residents who had previously known MDRO colonization status before the study was done. The researchers went in and swabbed every resident in the facility, and you can see the bottom portion was what they discovered. They discovered a lot more patients were colonized than they thought. When I look at this, it gives me 2 points to think about and bring into clinical practice. Number one, we know that almost half of our residents or facility are colonized with MDRO organisms. So therefore, if we get a culture result and the patient does not have symptoms of infection, they don't qualify in our criteria for treatment, we know that they are colonized. We say, over half of our patients are colonized with MDROs. It also tells us that we need to be vigorous with our infection control policies, because half of our residents are colonized with MDROs, and we do not want to spread. We don't want to put other patients at risk. So we need to be extremely vigilant with our infection control policy. So this is what this study tells me. So how do we know when to test if we suspect someone has an infection with an MDRO? So we know about half of our nursing home residents are colonized. We have to know when to test for an infection and which tests to order, because if we have a culture that's positive for an MDRO, it might or it might not indicate that the resident has an infection. So it's really a good idea to determine first that we suspect definitively that this resident has an infection prior to obtaining a culture result. So then we don't have a culture result that's positive and we're not sure what to do with it. Because once we have a result, we have to address it. Once we have a test result, chances are we have to address it. We might have a family member saying, my mother had Pseudomonas in her urine. What are you doing about it? So it's really important to think about what you're going to order prior to having that test, because once you have the test result back, you can't go back in time and not have that test result. There should be a clear indication that symptoms are most likely caused by an infection prior to initiating treatment. I wanted to illustrate this with a case that I dealt with recently. So an 88-year-old resident, advanced dementia, had one emesis, one episode of vomiting, and then she had one episode of diarrhea. She was lethargic immediately following the episodes, and the facility was really great and started IV fluids with normal saline. Vital signs were all stable. So this was a resident that could not give us history, couldn't tell us what her symptoms were because of her advanced dementia, but her vital signs are all normal. She's afebrile. The attending physician was called about what happened and immediately ordered CBC, a CMP, UACNS, blood cultures ×2, a D-dimer, an EKG, and a chest X-ray. So a pretty extensive workup for some lethargy with emesis and diarrhea. The resident was at her baseline 4 hours after the episodes of vomiting and diarrhea. So in this case, I'm not so sure that all of those tests needed to be ordered, especially the D-dimer, considering, I know we're talking about MDROs, but a D-dimer is typically going to tell us if the patient potentially had a PE, she was on room air, oxygen saturation was fine. So, in this case, we potentially might have to deal with a urine culture that really doesn't fulfill criteria for infection. And then we have to determine if we're going to give her antibiotics that she really doesn't need because she doesn't qualify for an infection according to criteria that we're going to talk about. So appropriate antibiotic use. All residents in nursing homes with high rates of antibiotic use are exposed to 24% greater risk of antibiotic-related adverse events. These are all residents in the nursing home. So when you're giving patients antibiotics in the nursing home, you're affecting all residents in the nursing home. Adverse events include C. diff or antibiotic-resistant organisms. So it's something to think about. If you give antibiotics to one resident and they get C. diff, if they needed the antibiotics or not, you're putting all residents in the facility at risk for C. diff because you gave that one resident antibiotics. I thought this statistic was really interesting. Each day of antibiotic use in a nursing home is associated with 0.4% increased risk for antibiotic harm for each resident. So each day that you give antibiotics, each resident in that facility is bearing the burden of antibiotic-related harm. This is why we really have to be careful about antibiotic use, and we really have to be vigorous with our antibiotic stewardship. So when do we know it's an infection? I'm sure you've all heard of the McGear criteria, and this is more of a surveillance tool, and it tells us when an event can be defined as an infection. So this is not clinical criteria. This isn't how you decide to initiate antibiotics. We'll talk about what we use for when we want to initiate antibiotics, but this is not that. We have to have all symptoms must be new or acutely worse. Alternative non-infection causes of symptoms are considered prior to the event being determined to be an infection. We can't just say, throw it in the infection wastebasket and we're done. No, we have to make sure we consider non-infectious cause of symptoms. Like in our prior patient study, we have to think about, did she have a vasovagal episode? Is she having a stroke? Is she having an acute kidney injury? We have to think about non-infectious cause. An infection is not identified based on one piece of evidence. So if we have a positive urine culture with MRSA in it, that does not tell us that we have a urinary tract infection. We need to have the entire clinical picture fit urinary tract infection before we make a diagnosis. So I don't know if any of you have heard of the Choosing Wisely campaign. It is an initiative of the American Board of Internal Medicine. I would highly encourage you to go to the website. It's really wonderful resource to kind of determine how we should be making decisions. And I pulled this up because this is the Society for Post-Acute and Long-Term Medicine. And one of their Choosing Wisely initiatives talks about asymptomatic bacteria. Asymptomatic bacteria is essentially bacteria present in a urine culture that is not causing an infection. Even greater than 100,000 colony forming units can be asymptomatic bacteria. And it's one of the major drivers of increased adverse drug events, overuse of antibiotics. So we have to make sure that clinical criteria is met. Went forward there. We have to make sure that clinical criteria is met prior to initiating antibiotics, and we'll be talking about which criteria we should use. So which criteria we can use? McGeer criteria, as I said, is used for surveillance purposes. It determines if an event should be counted as an infection. It's not a clinical tool. Our LEB criteria is what we should be using as a guide to determine when antibiotics should be initiated in every patient encounter that we think could be an infection. This errs on the side of treating likely infections because, as we said, in our resident population, they get sick fast with sepsis, especially with MDROs. So this criteria does err on the side of treating likely infection. So this is what we use to determine if antibiotics are appropriate in an event. I also wanted to pull up the Improving Outcomes of UTI Management, the IOU. So this criteria is based on the presence that most UTIs that we see in the long-term care setting are uncomplicated cystitis. They're not sepsis, they're not urosepsis. So this tool helps us differentiate if we have an uncomplicated UTI or we have asymptomatic bacteriuria, which is colonization and not an infection. So I'll show you that, and you can pull that up in the slides. So this is your McGeer criteria. This is going to determine if this event that happened can be classified as an infection. This is not going to tell us if we initiate antibiotics. And you can kind of look through all of these criteria to determine if the event was an infection. The LEB criteria is what we should be utilizing to guide us with antibiotic treatment. So as you can see, residents without a urinary catheter, acute dysuria alone, or fever with one of the following symptoms. So if we have a patient who has dysuria, they have burning with urination, or if they have a fever, and then they have one of the following: urinary urgency, urinary frequency, suprapubic pain, gross hematuria, urinary incontinence, and we have a positive urine culture, we can go ahead and treat that as a urinary tract infection. And residents with a urinary catheter have to have at least one of those symptoms, and then we would go ahead and treat. So we're more sensitive to treat residents who have a urinary catheter with this criteria. The IOU algorithm is, you can just kind of follow along, and this is going to differentiate whether we are going to treat this as a possible urosepsis, if we're going to treat this as a simple cystitis, or as a asymptomatic bacteria. And I think this is really important, and you can document in your notes that what criteria you utilized, just to justify your actions. So these criteria are available for any kind of infection you suspect with an MDRO. This is for skin and soft tissue infections. As you can see, You initiate antibiotics if you have new or increasing purulent drainage from the wound, skin, or soft tissue, or at least two of the following symptoms: fever, redness, tenderness, warmth, swelling. So another great tool. These tools are found in the AHRQ. They have a huge antibiotic stewardship toolkit, and you can download all of these criteria. This is for respiratory infections. Again, you can kind of read through the criteria. So I would encourage you to post these in your facility so your providers know that we are utilizing these criteria for appropriate antibiotic prescribing. And I would say that they, you might treat individuals that you perhaps wouldn't. It just is going to guide you for appropriate antibiotic prescribing. So whenever I think about long-term care management, clinical management, I think about low-hanging fruit. Let's use checklists prior to obtaining urine or other cultures to determine if the culture is needed or if antibiotics are needed. Use checklists after culture is obtained to determine if the antibiotic is needed. More challenging than the first one, right? Because once we have a culture, it is exceedingly challenging to not want to treat that culture. Use checklists to communicate with families, medical powers of attorney who ask for cultures. I do this all the time in clinical practice. I think it's really important to let families know why you are doing what you are doing. And use checklists as a reminder that it is not standard of care to test for cure. We should not be getting chest x-rays to check to see if pneumonia is gone. We should not be getting repeat urine cultures to determine if our UTI is gone. I wanted to pull choosing wisely again, because number 12 is don't order routine follow-up chest imaging for post-acute and long-term care residents with community-acquired pneumonia whose symptoms have resolved within 5 to 7 days. So we do not check a chest x-ray after antibiotics have finished. It's just going to muddy the water, and we're not going to repeat treatment unless the resident is showing signs of infection according to criteria, which we just discussed. I wanted to bring up the all-important SBAR, Situation Background Assessment Recommendation. That's what SBAR stands for. It's a tool. It guides the initial assessment. These should always be used in long-term care setting when you have a change in condition, when you want to communicate with the provider. It helps organize your thoughts in order to provide information to the provider. It helps you slow down and think through complex problems, which we need to do more of in the long-term care setting. It's not often necessary just to make a knee-jerk fast decision. It is really a good idea to slow down and think about why we're doing what we're doing, and the SBAR helps. This is a suspected UTI SBAR. You can utilize them for any type of infection you suspect. And then when you call your provider, you can say, I filled out the UTI SBAR, and this is what I'm finding. I think they would appreciate it. I wanted to talk a little bit about chronic trach patients, because I know some of you have chronic vent units. So with trach patients, bacterial colonization is a big problem, and I'm sure you are all well aware of what happens when you have increased sputum in a patient who has a chronic trach, and what do you do with those sputum results if the patient is not showing signs of infection according to criteria. So this is a study that was done following 39 patients with chronic trachs. Almost all were colonized with pathogens at the stoma site or trachea, mostly with Staph aureus and Pseudomonas, and I'm guessing they're mostly MDROs. 18 of the 39 patients were treated for respiratory tract infections during the 12-month study period. So a good amount, almost half, were treated for respiratory tract infections with antibiotics during the year that they looked at these patients. When the researchers went back, only 5 of these episodes, 5 of the 18, actually were classified as pneumonia. So what the researchers were saying is that there was an overtreatment according to sputum results or from culture results that were taken from the stoma or the trachea. So they concluded that patients with chronic trachs have low risk of developing pneumonia despite significant colonization of stoma and trachea. So this is something to keep in mind going forward in treating your patients. So take home points, MDRO infections are a major concern in the nursing home population because they are at risk of developing severe infections from these organisms. It's important to understand the difference between colonization and active infection in order to determine when we need to initiate antibiotics. Clinical criteria provide guidelines to determine when we start antibiotics. It's important to utilize them. It's important that we are all using the SBAR to help guide assessment, aid communication, and then determine best action when we communicate with our provider. And now we'll see some questions. I think there are some questions in the chat, Kathy.
There are, and I've answered a few of them. A few people here were asking about the presentation slides, and I will be emailing those to everybody later this week along with the recording. And a couple people, I've been dropping in the chat links to some of those resources. I haven't put in the links to the McGeer and the Loeb criteria yet, but I was about to fetch those, so I can get those in just a moment. Assuming that the ones that you put in the citation is the link to
yes,
that you screenshot.
Yeah, and you can find McGeer and Loeb, and they're available at that AHRQ toolkit.
All right, and I'll get you those links in a moment in the chat, but you'll also get the slides later this week, so you'll be able to have them on hand there too. Someone has their hand raised, so if you would like, I can go ahead and give Carissa the ability to unmute yourself. Okay, Carissa, if you would like to ask your question out loud, you can unmute yourself.
I actually had the question answered by yourself a moment ago, so we're good there. With the other links that you said that you're going to be, I see the suspected UTI SBAR toolkit. The other links you're going to be posting in the chat, you said?
Yes, for the McGeer and the Loeb criteria. And if there was any others that I missed, let me know if you would like me to put those in the chat too.
Perfect, perfect. This way I can print them out. And then the slides themselves, you're going to send that to the email that you have as far as the contact.
Yes, that's correct. Whatever email everybody here registered with will be on my mailing list. And so you should get them. And I will also be posting them to our website that same day. Friday morning is usually when I get those out. So qualityinsights.org/QIN is our website. And then there's the multimedia tab is where we post all of our recordings, links to the slides and some other resources.
Okay, perfect. That was a fantastic presentation.
Yeah,
thanks. Yeah, any other questions, and if you don't want to ask here, you can feel free to reach out to me via email. I'm happy to answer them.
So we got a couple questions in the chat. It says, what about test for cure, VRE in urine? Would you repeat urine culture for VRE only without test for cure would you discontinue isolation? That one's in the Q&A if you want to read that one yourself.
Let's see.
Instead of listening to me read it.
So is that, maybe I'm pulling up the wrong one. So I don't advocate testing for cure. If you have an infection and if you have an infection according to criteria, it is not indicated to test for cure. I don't know if Jennifer, if you want to speak to the infection control aspect of things with a patient for VRE. And then there's another question. I think that this is linked for the enhanced precaution proposed by the CDC. I don't know if anyone else on the call knows about that enhanced precaution. we might have to do some research.
Well, I don't know I think if Andrea means the enhanced barrier precautions that they're talking about, and we had given a presentation on that prior, she can let us know if that's what she means.
Yeah.
Yes, it is, she says.
Yes, okay. And that is something that what we had decided at that point in time is it wasn't anything that officially you had to do. And if you put enhanced barrier precautions into place, you would need to make sure that your policies and procedures addressed it and that you followed everything that you had. And we can get more information on that if, you know, Andrea, if you want to reach out, we can. At the present time, it's not required.
So we got some clarification on the previous question about VRE. It says I was using VRE as an example. So when would you discontinue isolation? And Jean, this was in the Q&A. There's two separate.
Okay, so did they put it in?
Yeah, if you see the symbol that says Q&A with the little speech bubbles, that's where that question is.
So these people are typically going to remain colonized with VRE in the urine. So you would not test for cure. So there would be no, because they're going to remain colonized. So, you know, the problem is you're going to keep treating and testing and treating and testing, and that's not appropriate. So once you treat, you know, that's once you treat for infection, if you are sure that the patient has an infection and you are going to treat that infection, then you are not going to check again for cure.
The other part of that, Jean, she said, well, when would you discontinue isolation? I know that's a question that comes up a lot. If you're not testing again, then when do you make that decision to end isolation?
So I don't know if this is, you know, per facility, and maybe Jennifer can kind of speak more of that. You know, what I say in my facility that we need to use, you know, if it really depends on is what is going on, if the resident is continent, if there is pericare going on with the CNAs. So, you know, we have to be very careful with our infection control, keeping in mind that the resident is colonized with an MDRO and act accordingly.
Yes, and I agree with that as well. You know, for discontinuing the isolation, you have to look at the symptoms and, you know, the course of the treatment that you've done. So.
Thanks, Jennifer. So for those of you who don't know, Jennifer Brown is Quality Insights Infection Control Preventionist. So we have another question following up on that. It says, so what about enhanced based precautions for people with colonization?
So this is a really tricky thing. I think that we really need to be cognizant about infection control. I would honestly assume that everybody in the facility is colonized with an MDRO and act accordingly. That doesn't mean that we're isolating people, but that we're usually in good infection control tactics when we are treating residents, if we're doing pericare and all of this kind of thing, and we're just acting like MDROs are prevalent, that they're out throughout the whole facility and acting accordingly. Is there another question?
So the follow-up says there's a thin line with quality of care and keeping someone that is there's a thin line with quality of care and keeping someone that is incontinent in isolation forever.
Correct, right? And if it's contained in a brief, you know, that's not right. That's not, you know, it's not everywhere. So, you know, I think that we just have to remind staff that when you are performing any kind of peri-care, that you have to treat each resident like they are colonized with an MDRO and act accordingly with our infection control procedures.
And I see someone in chat said, yes, standard precautions is paramount in preventing infections. And that's what we talk about all the time. Just, that good hand hygiene, proper infection control. Your basic infection control is something that you need to continually educate and talk to staff about. So yeah, that's absolutely right.
Yeah,
So
you cannot isolate patients forever. Absolutely not. And it's more of a dignity, if you put up a sign, that is a dignity issue. That's a dignity tag. So it is up to us to make sure that we are really vigilant with our infection control procedures.
So we have another question in the Q&A. Is there a compliance component on how we communicate and educate staff on EBP?
EBP. What is EBP?
That sounds like enhanced barrier precaution might be a good topic for another conversation. If anybody wants to reach out to us individually with questions that would give us an opportunity to prepare for that. But we have these weekly webinars, every Wednesday at 2:00. Literally we were just talking about some additional topics, and that sounds like a good one. So maybe that's one that we'll have upcoming. And in the meantime, if you need something answered, that's something that we'll look into, and we will get information, and that sounds like it might be a good topic presentation for one of these webinars coming up soon.
Yeah, I'll delve into EBP.
I was digging around in our archives. We had an episode called Enhanced Barrier Precautions and Overview back on October 5th. So if anybody wants the link to that recording, I can send that.
Yeah, and Cindy, who actually gave that presentation, is not with us any longer. So, and that's what I was thinking too. I've got to go back and listen to that again. But yeah, we will definitely, Shelley, we'll make sure that we do that and get that information.
Beverage companies are working together.
Chris, I have myself unmuted when the YouTube video starts playing. I put the link to that episode in the chat. Sorry, that video interrupted you, Penny.
No, that's okay. Now I see someone else said that would be appreciated. So yeah, I think that's one of those things that we'll bring that up again, and we'll be prepared to address that on another. I don't think we already have something planned for next Wednesday, so I don't think that topic will be covered next Wednesday, but we will do it in the near future.
Next Wednesday is the live Q&A, then the following Wednesday, I think we have an open slot for a new topic.
Oh, for the live Q&A, we'll maybe if you join, we'll make sure that we have some answers to some of those enhanced barrier precaution questions.
All right, so lots of great questions. I didn't even get to read like my little script that I get to read while we're waiting for people to submit questions. So I was going to remind everybody that again, next week's topic will be a live Q&A with our panel here. And if you'd like to submit a question in advance, I'm going to drop again in the chat the form that you can do so. Or you can ask during the webinar, but this way they get a chance to look some things up ahead of time. And we also invite you to join our live chats every Tuesday and Thursday afternoon, or Tuesday and Thursday at noon. And Deborah Wright is there each week to answer questions on topics like quality improvement initiatives, infection control, or MDS coding. And we put the links to those live chats in our webinars and in our webinar email reminders and our last minute lowdown newsletter, which goes out each Friday. And if you're not on our mailing list for either of those, but would like to be, you just can send me an email and request to be added to the mailing list. And I will drop my email in the chat here in a moment, along with Dr. Storms, in case you need to get in touch with us. But either way, everybody will be getting the recording from me later this week, probably Friday morning. And if anybody else has any questions that we haven't answered yet, please go ahead and put them in the chat or the Q&A at this time. or again, you can raise your hand if you would like to be unmuted. So we've got a couple more questions, it looks like. This one says, I'm a bit confused in that we cannot keep residents on isolation forever, but we also have to assume colonization is keeping them on isolation forever.
So no, we're not keeping them in isolation forever. That would be a dignity issue. That would be impede their quality of life. What assuming colonization does is keeps us vigilant in our infection control practices. Keeps staff vigilant about infection control practices. That's what knowing a patient is colonized or assuming a patient is colonized does. Just keeps us vigilant.
All right, thank you. Let's just take another minute or two here. We've been here for 45 minutes, so getting close toward the end. Dr. Storm, at this time, do you have anything else you would like to add?
I don't think so. Thanks everybody for coming.
Excuse me. All right, in that case, I think I will wrap us up. Before we sign off, we'd like to ask everyone here to please answer a short evaluation of today's webinar. It's an anonymous evaluation and it will show up as a pop-up as soon as I end this webinar. And if you have a couple minutes to fill that out, we would appreciate it. I'd like to thank you all for joining us today. And Dr. Storm, thank you for joining us again. And we hope to see you all back here next week.